the pilot.
Thanks, Russell. I'm just going to give an overview on fractures of the talus. Bit of anatomy. The talus is considered a bony meniscus because it doesn't actually have any muscle attachments. 2/3 of the surface is cartilaginous, and it has 3 major joints to the ankle, to the subtalar joint and the talonavicular joint. The subchondral bone is very, very hard. It's the way the fibula are aligned, and therefore anything to fracture the talus requires a high energy. In considering talar fractures, one must consider the blood supply. So there's anastomosis that goes through the sinus tarsi. The branches are from the dorsalis pedis and posterior tibial arteries. Importantly, the deltoid branch, which comes off the posterior tibial artery, needs to be preserved, especially when you're dissecting through an anteromedial approach, because that supplies the body. And if that's disrupted off the medial ligament, it can increase your rate of AVN. So the different types of talar fractures consist of neck fractures, body fractures, and what I term peripheral fractures. Peripheral fractures can be divided into lateral process fractures, or the snowboarders fractures, posterior process fractures, and also osteochondral lesions. Now, osteochondral lesions will be covered by one of my colleagues today. So what's the mechanism of injury? Usually it's a fall from height or a high energy motor vehicle accident. Only 10% is an indirect transmission of force. Over 40% involve the talar neck. They talk about an axial force between the tibia and the calcaneus, and the subtentaculum on the medial side of the calc acts as a lever. So depending on the amount of dorsiflexion or plantar flexion, the force goes through the neck or the body. As I mentioned, high energy injury, axial force, represented with swelling, hematoma, reduced range of movement, can't wait there. If they have an associated dislocation, they'll often get skin tenting. It can be an open injury, which increases the rate of infection. Look for neurovascular deficits, compartment syndrome. Your investigations are usually X-ray and also CT scan. Talar neck fractures, we all know the Hawkins classification. Another guy called Marty did modify this. But essentially type 1 is a non-displaced neck fracture. Type 2, a neck fracture associated with dislocation of the subtalar joint. Type 3, dislocation of both the subtalar and the tibiotalar joints. And type 4, which is at later, dislocation of the subtalar, tibiotalar, and the talonavicular joints. So what are the options for treatment? If you have a truly undisplaced body or neck fracture, you can manage these non-operatively, but most often than not, if it's associated with a dislocation, the principle is you must reduce these early. There is good studies that show that if it is associated with dislocation, the AVN rate increases. Open fractures obviously require early debridement and fixation, and displaced neck and body fractures, as opposed to ones that have dislocated, although we try and internally fix them as early as possible, it does not seem to increase the rate of AVN if you fix them within a reasonable time. So what are the operative approaches? I remember going through training, you don't really see these fractures often, unless you're at the hospital. And if you're faced with one on your first day as a consultant, you kind of think, well, what am I going to do here? Often bilateral approaches are required, so anterior medial and anterior lateral approaches. Your options for fixation include cannulated screws, so often I'll use a 4mm Asmus cannulated screw. Using titanium screw is better than stainless steel screws, because if there is AVN, the MRI is more likely to have less distortion with the titanium screws. The pattern of injury with the neck and body fractures often go into varus, so you have to be quite aware of reducing that, and you can look at it from the medial and the lateral side to make sure you have a good reduction. Often mini plates can be used and just tucked underneath the medial side to jack out that medial column. For open fractures, in fact, you can use an X-fix to debride the wound, make the limb safe, come back another day. So this is a diagram of the anterior medial and lateral approach. The most common anterior medial approach is simply between tib-ant and tib-post. Watch out for the saphenous neovascular structures. I mentioned the deltoid, just tuck underneath the medial malleolus. See if you can tuck just anterior to the deltoid when you're accessing the neck and the body. If required, the incision can be extended more proximally and can do a medial malleolar osteotomy. The lateral approach, I generally use a simple anterolateral approach, but you can also use an Olliers type approach, which is a horizontal type incision, which runs across the front of the ankle joint, past the fibula, and to the peroneum. And this lets you access not only the front of the neck, but also if you have a lateral process fracture, allows you to tuck just a little bit more posteriorly to get to that. So this is a Hawkins type 2 fracture. Oh, anyway, we've got some candidates in the front row. What do you see in the CT here? Gentleman in the pink. Perfect. In the corner. One looking around. Yeah?
So this is on the upper left A-fan lateral plane. Most strikingly, this patient on the upper, on the plane X-rays, you can see a lateral process fracture on the AP.
Call it subluxation, or would you call it a little bit more than subluxation?
Well, it's still in contact.
I'd really call that a pretty good dislocation. The posterior facet is almost offended. That there should be just over there. That's all. Don't argue with the examiner. Come back next year. Thank you very much. So this is one method of internal fixing, as I mentioned, cannulated screws done through anterior medial lateral approaches, and you can see the lateral process fractures also been fixed there. Now, what's this arrow pointing to? Candidate 6. What does that mean? Mm-hmm. Mm-hmm. So this is a sign that? Yeah, so when you see this sign, the AVN is a good sign. Okay? It means the AVN rate is less likely. So you can pass. So this is at 2.5 years. So Talus fractures, complications, I mentioned infection, open fracture, dislocations, you have a high rate. AVN is associated with Hawkins type classification with the rates of AVN as listed. You've described the Hawkins sign excellently. Well, it's a sign that we look at 4 to 8 weeks. Radiolucency, it does indicate bone remodeling, and therefore the AVN risk is low, so it's a good sign. Post-traumatic arthritis is unfortunately high. Malunion and non-union is also high. So I mentioned be aware of various alignments that it tends to go into and the medial comminution. Prognosis depends on the severity of the injury and quality of the reduction of fixation. We've spoken about that. We've also spoken about AVN correlates to the degree of dislocation, and therefore any dislocation is a medical emergency. You've got to reduce it. You don't necessarily have to fix it that night, but you have to reduce it. Often you have to fix it to get it reduced though. Talar mallar non-unions, corrective osteotomy and bone graft and re-internal fixation is poor. So once you've missed the boat, come back with a varus malunion, very difficult to re-break it and get it into a good alignment. So you may consider that in a young active person with good bone stock and preserved joints. And unfortunately, if they do go into post-traumatic osteoarthritis, we're looking at various fusions of affected joints. The lateral process talar fractures, just quickly, often associated with subtalar dislocations or subluxations. The lateral process fracture is usually associated with inversion and dorsiflexion type injuries. So the navicular goes medial to the talus and it actually lifts off the lateral process, and then an axial force tends to drive it through that particular area, causing a fracture. If it's non-displaced, then you can definitely treat it non-operatively, and if they do have symptoms of impingement later, you can excise it. However, if it is displaced or it is a large fragment, consider internal fixation. Malunion can lead to impingement of the subtalar joint and lead on to arthritis. This is an example of lateral talar fracture. There you can scope them. This was reduced and fixed with some screws. Posterior process fractures. It's where the FHL basically comes down. The groove on the lateral and medial side, that's the lateral process, and medial side is the medial process. So the medial tubercle and the lateral tubercle. If displaced, can cause posterior impingement. Once again, non-displaced, non-operative, displaced or symptomatic, you can excise. The signs clinically that you can look for impingement, specifically with the lateral side, that's not that clear, but that's the fibula. But look for just inferior and anterior to the fibula, and often that's where the lateral process sits. And the posterior impingement sign, forced plantar flexion, and have a feel just behind the metamalleolus. So in summary, talar neck and body fractures, open injuries, fracture dislocations, there's a medical emergency. High AVN malunion and non-union rate. Any displaced fractures needs anatomical reduction, internal fixation, progression to arthrosis is high. Consider your anterior medial and lateral surgical approaches. And we've just gone through the lateral and posterior process fractures. Any questions?